I'm going to spend this 20 minutes trying to show you what is new in the area of portal hypertension. I have no disclosures. I want to thank Patrick Marcelin once more to inviting me for this meeting. No disclosures concerning this topic, but I do have a disclosure probably concerning each time I come here on winter time, and this is a close relationship with other people that is responsible for this that I face every year. So I'm very grateful for Natalie and Richard, and I may sign an agreement for next year. Hope I could not pick this morning in the NASH session, at least this opportunity. So to get into the field, we have to first place the patient into one of the categories of portal hypertension. So differentiate very well if the patient is decompensated or in a compensated stage. And it is very interesting to focus in the compensated cirrhosis field because these patients behave from a phenotypic point of view exactly the same. And we have to differentiate very well if they have just mild portal hypertension or clinically significant portal hypertension defined as a hepatosvenous pressure gradient more than 10 millimeters of mercury, and if that is the case, if the patient has varices or doesn't have has varices, because this allows a risk stratification of the patient and also to take the correct therapeutic measure. What's new in the pathogenesis of portal hypertension? Well, there's nothing really new, but I'm going to show some mechanisms because they are important later for what it may be new in the treatment of portal hypertension. So we know from years now that there's in the initial years of the disease, there's an increase in intrahepatic resistance, and this is the main determinant of portal hypertension, but then further on there's also the addition of splanchnic vasodilation, increased portal blood flow, development of collateral circulation. Let's see a little bit what happens here in the liver within the next first years. This is there are the first years of the disease. There is already portal hypertension. As you can see, the grade HBPG is from 6 to 10. Here is an important opportunity to target or to intervene on these patients to prevent the outcome of what I recently mentioned of clinically significant portal hypertension. Because when patients reach this stage, more than 10 millimeters of mercury of HBPG, when he is a candidate to develop life-threatening complications. So everything we can do here will be of great help to prevent these complications. There's a structural component in this intrahepatic increase of resistance and a dynamic or functional component. But what is important to know is there are two major players. There are these two cells, hepatic stellate cells and sinusoidal endothelial cells. And this is stimulated or challenged by inflammation, independently of the cause of the disease. Also, when the patient has already a cirrhosis or a more severe portal hypertension by translocation from the gut microbiota and bacteria-derived products like LPS or others that also stimulate these two cells. There's also a prothrombotic condition, as you know, in cirrhosis that is also targeting these sinusoidal cells and all the context. So there's a crosstalk between the two cells. One stimulates the other, and for instance, with vascular endothelial growth factor, angiogenesis, and all this derives in fibrogenesis angiogenesis, capillarization of sinusoids, loss of fenestra, and eventually microthrombosis in the intrahepatic circulation. So this is important to understand that these are the main responsible for the increase in what we call fixed component of intrahepatic resistance, which is about 75% of intrahepatic resistance, and also probably the dynamic component of intrahepatic resistance, mainly due to the activation of the contraction of hepatic stellate cells and of increased production of nitric oxide, decreased production, sorry, of intrahepatic nitric oxide due to the disruption of the endothelium. So if we have that in mind, we could target in this stage of the disease, the etiology of the disease, for instance, by blocking inflammation. We could use antifibrotic agents if we have them, anticoagulants, or we could target in a later period intestinal bacteria, probably, and we can be successful in these patients. Now, what's new in the diagnosis of portal hypertension? We know this for years. We have been using invasive tests, endoscopy to screen varices, portal pressure measurements to define clinically significant portal hypertension. But it's now the non-invasive tests which are we have focused in mostly liver stiffness measurements in patients with clinically significant portal hypertension. This has become an area of much interest because this may replace invasive tests in these patients as prognosis markers, as determinants of different therapeutic measurements as we are going to see. And within this, for instance, the last Baveno consensus recommended FibroScan to identify the presence of CSPH and stiffness more than 21, equal or more than 21 kilopascals, rules in CSPH, at least with high sensitivity and specificity. And also the ability to rule out the presence of high-risk varices if the patient has less than 20 kilopascals associated with 150,000 platelets. That patient is very unlikely to have high-risk varices. And and with this measurement, we can spare or avoid at least 20% of endoscopies. Now let's go into the treatment of portal hypertension, and these are the recommendation and American and European and Baveno recommendations. There is now no indication, there has never been an indication for beta blockers to prevent the formation of varices or to treat patients with small varices to prevent the increase in those varices, and this was demonstrated years before in this very clear trial by Roberto Grossman, where he showed that in patients with more than 6 of HBPG, these beta blockers were not effective, and this is logical, is expected, since, as I said before, in this stage of the disease, there is no increase in splanchnic vasodilation in portal blood flow, so there's no expectation for beta blockers to be effective. On the contrary, primarily prophylaxis for variceal bleeding is indicated in patients at a high risk of bleeding, and these are patients with medium or large varices, but also patients with small varices and red wave signs, and patients with decompensated cirrhosis and small varices. In patients with medium or large varices, either beta blockers or carvedilol or band ligation can be used to prevent the variceal bleeding. But what is new now is that patients with clinically significant portal hypertension are not only at risk of bleeding, but are most important at risk of developing hepatic decompensation and of increased death. You can see here the two groups of patients in this old study with and without clinically significant portal hypertension, the probability of clinical decompensation, and also the increased survival in patients that have less than 10 millimeters of mercury. So these authors, and this is a very important study, the Predesi study, took this issue and to evaluate really if beta blockers were effective to prevent decompensation in patients with clinically significant portal hypertension. So it was a multi-center randomized trial in Spain, and this was published last year in The Lancet. And they took 200 patients. They tested acute infusion of response to propranolol. All the patients had CSPH, so more than 10 millimeters of mercury of HBPG. And so there were responders to propranolol, and they randomized patients to propranolol or placebo, and non-responders, they put the patients on carvedilol or placebo. And the primary endpoint was decompensation or death. And they followed these patients for a median follow-up of 36 months. And have the main result of the study, patients that received beta blockers, either propranolol or carvedilol, had almost half the incidence of decompensation, so was reduced by half, mostly the development of ascites. So this is a very important study because here there was not an objective to prevent bleeding, but to prevent decompensation. So this trial is the first study showing that long-term treatment with beta blockers decreases almost by half the risk of decompensation, mostly ascites or liver-related death. And these results might result in a new indication for beta blockers, besides the indication to prevent bleeding in patients with compensated cirrhosis. And of course, it's HBPG measurement constitutes a limitation because this is not available everywhere, but non-invasive tools such as FibroScan, as I mentioned before, might be helpful probably to select patients in the near future. What about anticoagulation in these patients? Is there any news? We had this trial known by everybody almost 10 years ago with enoxaparin versus no treatment for 1 year, showing that anticoagulation delayed the occurrence of decompensation and also, more important, improved survival in patients with cirrhosis. The mechanisms for this: it improves intrahepatic microcirculation. We talked at the beginning about microthrombosis, decreases intrahepatic resistance and portal pressure, but also improves intestinal microcirculation, decreasing bacterial translocation. So there are many studies now. One of those I chose is this one because it should be finishing now with rivaroxaban, 10 milligrams a day versus placebo. The primary outcome is survival at 24 months, and we are probably going to see the results of this multi-center Spanish study during this year. Concerning the treatment of acute body cell bleeding, you have a dozen of musts here, but I'm just going to say a few words about tips, tips or early tips. These are the first results with tips in acute varicose bleeding, which was first indicated in treatment failures of pharmacotherapy or endoscopy. TIPS has been always very effective to control bleeding, as you know, almost 100% of efficacy. But in the first years, mortality was very high, between 35 and 55% in these patients. And all trials show that this mortality was associated with placement of the tips that was late in these patients when they had already multi-organ failure. So the question was, should tips be placed earlier in high-risk patients? And this was taken 10 years ago by the group of Barcelona, and they showed that when we put an early tips, this was within 72 hours after bleeding, selective patients, child B patients with active bleeding in this trial, and child C patients benefit from control of bleeding, and most important from increased survival. The Baveno consensus 5 years ago recommended early tips for these two populations, patients child B with active bleeding, or patients child C up to 13, but stated also that criteria in these patients should be refined, and criteria was refined in the last years. I show just one study with a large population. It's a multinational study, also with similar criteria of the original study. And this study showed that if effectively TIPS or early TIPS was effective in reducing mortality in child C patients from 10 to 13, but was not the case in child B patients with active bleeding. So we are going to see soon if this indication will change or not. Last is what about statins that have been in the field for many years now. You know, statins, besides the properties of lowering lipids, have very important properties in patients and in animal models with cirrhosis. And the mechanisms for statins is pleiotropic effects, antioxidative and anti-inflammatory effects, decreasing fibrosis and portal pressure, and probably improving also endothelial dysfunction and microcirculation, and also decreasing intrahepatic resistance and portal pressure. Several randomized controlled trials, I've chosen a couple of them, show that statin users, this is in compensated cirrhosis, was associated with a decrease in decompensation and with improvement in survival in these patients. And also a more recently trial showed that simvastatin at a dose of 40 milligrams a day was useful to decrease significantly mortality in a population of patients after the first bleeding, so when indicated on top of standard care for secondary prophylaxis. On the contrary, it was not effective in the prevention of rebleeding. So more studies probably are needed. These studies of the last year are going to be discussed probably in last Baveno, which is in 2 or 3 months. So the take-home messages: cirrhosis should be described and managed in 2 distinct clinical stages, compensated and decompensated, defined by the presence or absence of clinical over clinical complications. The identification of patients with cirrhosis and clinically significant portal hypertension, so more than 10 millimeters of mercury of HVPG, is extremely important because therapeutic measures are taken in those patients, and non-invasive tests will be of great help in the future to identify these patients. In patients with cirrhosis and CSPH but without varices, the objective of treatment should be to prevent clinical decompensation, and new recommendations concerning therapy related to this issue will probably show up in the near future. After an episode of acute variceal bleeding in patients at high risk of failure of rebleeding and early preemptive TIPS, so within 72 hours, from endoscopy may be beneficial in selected patients, maybe only in child C patients. Anticoagulation may improve intrahepatic microcirculation. From a theoretical point of view, but its clinical impact still needs further studies. And statins have shown to lower the incidence of decompensation and mortality in different populations in cirrhosis, and therefore they might become an additional tool in the management of these patients. So last, I want to thank 2 great masters, Jean-Pierre Benamou, who was my master years ago and the master of many people in this room on general hepatology, and my master on portal hypertension, who was Didier Lebrec. So thank you very much.
Thank you. I think you will leave.
Yeah.
I have just a short question before you leave. What is the rationale of statins in portal hypertension?
Well, as you saw, the rationale would be to, the mechanisms proposed is that it may improve intrahepatic microcirculation by different, by intrahepatic delivery of nitric oxide, intrahepatic because stabilization of the endothelium, but all this is theoretical. But in the clinical trials, it has shown a clinical benefit. So I don't know if we can link this hypothesis with the clinical benefit. It's also important to know that they are safe. In fact, personally, many in the field used to think, well, we are going to give 40 milligrams of simvastatin, for instance, in a patient with maybe decompensated cirrhosis, and the tolerance in these patients was quite good. It was only 3% of patients having related side effects. But it is still a field of debate.
And you use it?
No.